Morning to all. So today we are going to learn about alcohol use disorder, which is defined in your syllabus as alcohol mental disorder. Actually, it is a substance use disorder. We will be covering introduction part, epidemiology, etiology, clinical features of alcohol use, evaluation of the person, management of alcohol use disorder, conclusion with references. So let's start with introduction. Substance related disorder is an umbrella term under which all kind of substance fall, and it is because of repeated and excessive use of that substance that lead to impairing life or distress in the life or other occupational or social or scholastic underperformances. The substance can fundamentally change the brain chemistry or function. So if one use the substance, it goes into the body and then into the brain, and it causes certain type of changes because of which someone feels some kind of effect of it. The effect of different substances are different, and it can lead to wide range of physical and mental health issues if it is excessive and continuous for prolonged period of time. The various substances can be categorized as inhalants, cocaine, opioids, hallucinogens, marijuana, also known as cannabis, alcohol, and prescription medications also, like benzodiazepines and the drugs of opioid group. Basically, alcohol is a CNS depressant. Although one get to know that it cause excitement in behavior of the person, but in the brain it causes suppression of neuronal functions, which can affect cognition of the person, behavior of the person, and motor functions. So alcohol contains ethanol, which is a psychoactive substance, and it's a dependence producing agent. In low doses, it induces euphoria, means certain kind of happiness, sociability, and relaxation. So what happens is, because it's a depressant, so it suppresses the function of neurons, and inhibition which the person have is breached or break. So the person becomes more sociable because a barrier of his defense ecosystem is breached, and he becomes more euphoric, sociable, or you can say extrovert. And higher doses leads to cognitive impairment, loss of coordination, and eventually unconsciousness. When the abundance of substances rapidly increased in the brain, it causes more dysfunctions. Now the disorder, why it is called as disorder is, it has a pattern of alcohol use leading to clinically significant impairment or distress. Alcohol related disorder fall under the substance related and addictive disorder in DSM-5, and mental and behavioral disorder due to use of alcohol in ICD-10. So ICD-10 is International Classification of Diseases, which is followed by WHO countries, and in America the classificatory system DSM-5 is there. You know about the DSM-5 and ICD-10? You must have learned in the previous classes. Now the common terminology which is used in the context of substance use, we will discuss about it. One is abuse. Abuse is use of any drug, usually by self-administration, in a manner that deviates from approved social or medical pattern. The drugs can be used for medical purpose also, and therapeutic purpose also. For example, benzodiazepines are given for anxiety disorder, and barbiturates are used for curbing the seizure or epileptic activity. So it has a medicinal purpose also. If it is deviated from approval, then it is called as abuse. Harmful use, defined as a pattern of psychoactive substance use that is causing damage to health. Now the level of use is such that it is causing harm, and this damage may be physical or mental or social. It may be social and personal also. The diagnosis requires that actual damage should have been caused to the mental or physical health of the user. The term addiction. So addiction is a treatable chronic medical disease involving complex interaction among the brain circuits, genetics, environment and individuals' life experiences. People with addiction use substance in a way that become compulsive and often continue despite harmful consequences. So it becomes compulsive for that person and it leads to harmful consequences, maybe physical or mental. There is a condition called intoxication. Intoxication is reversible and transient state of altered consciousness, behavior and cognition due to recent substance use. The person has taken substance rapidly in a greater amount and he will be relieved by few hours or by few days. So this is called as intoxication. There is a term called withdrawal. What is withdrawal? Is a syndrome that occurs after stopping or reducing the prolonged substance use. The person is using the substance for many months or many years and he tries to cut down the substance or reduce the quantity, then it leads to withdrawal state, which may be physiological or psychological with the physiological and psychological symptoms. There is a term called as tolerance. Tolerance is the need for increasing the dose of substance. You must have known that in the pattern of substance use, the person starts with low dose and by the time they increase the dose to get the same effect from the higher doses of that substance, maybe alcohol also. Cross tolerance, when tolerance to one substance leads to tolerance to other. For example, you have heard about the substance abuser do not get anesthesia as with the same dose with the other person gets during the pre-anesthetic checkup during the anesthesia phase because of the cross tolerance. Certain drugs like midazolam are used for anesthesia, which is a benzodiazepine drug, and if a person is abusing benzodiazepine other drug may found be cross tolerant to midazolam. This is called as cross tolerance. Dependence. Dependence is a state in which an individual continues substance use despite negative consequences. What happens in dependence? We say the person is dependent on the substance when he uses the substance while having the negative consequences, maybe physically or mentally. Physically, like alcoholic liver disease. The person knows that liver is weakened or damaged. Despite of that, he used to use the substance. Dependence also has the feature of tolerance, feature of withdrawal when he tries to cut the substance, and compulsive drug seeking behavior. The drug seeking is compulsive. He himself voluntarily forcibly seek the substance. And dependence can be physiological or psychological. There are certain criteria for diagnosing dependence, and it has both the criteria, the physical criteria and psychological criteria. Now the epidemiology. The alcohol accounts for 5.3% of global death and 5.1% of the global disease burden. 14.6% of Indian population uses alcohol, and it accounts for 20% of all injuries uh, due to RTA or other kind of violent or homicidal behavior. It is more common in men, but it is rising in females. High prevalence of alcohol use was found in states in India such as Chhattisgarh, Tripura, Punjab, Arunachal Pradesh, and Goa. Onset is often in late adolescence or early childhood. It is quite common in adolescent period and early adulthood period. Though there are 16 crore users in India, 5.7 has problem with the substance, this alcohol use, and 2.9 crore dependent on the substance, the alcohol use. The prevalence by the population group are as follows. Total population is 14.6%. All males are among the substance users are 27%. All females are 1.6%. Children from 10 to 12 years are 1.3%, and adults, including both the genders, less than 18 years are 17.1%. So they are the users of alcohol, may be dependent or not.
These are out of the
Etiology, why it happens, what are the causes of alcohol use disorder, divided into three: biological factors, psychological factors, and social factors. So by and large, biological factors can be gender, maybe physical illness, painful conditions, mental illnesses. In mental illness, other psychiatric illnesses, the pattern of use is more prevalent. Genetic of the person, the neurochemistry of the brain, and reaction to stress. In psychological factors, learning, the personality of the person, the behaviors, emotions, the coping skills, resilience, and traumatic experience in past or in the childhood period may play a role. In social context, social support to use the substance. If it is commoner to use that substance in that society, the chances of abusing that substance are high. Socioeconomic status also play a role. Childhood experiences, housing, food security, education, employment, and discrimination, all these play factors in causing the alcohol use disorder. In biological factors, first is genetic factor. So heritability of alcohol use disorder is around 50 to 60% if genetic loading is high in the family. If first degree relative of alcohol, if the first degree relative of a person is abusing alcohol, so there are 3 to 4 times higher risk of developing alcohol use disorder. Genetic variations in genes like alcohol dehydrogenase and aldehyde dehydrogenase, which influence alcohol metabolism, may also play a role. The person who is having lesser number of these receptors or the enzymes, so this also cause the and are the potential for developing alcohol use disorders. A neurobiological mechanism which happens in the brain, the dopaminergic reward system, you must know about the reward system in the brain. The alcohol increases dopamine release and reinforcing addictive behavior. Any kind of pleasure we get by any kind of activity like playing some game, having certain kind of food, having certain kind of activity, conversation with certain kind of your good friend, releases dopamine to get that pleasurable effect. What happens in substance use disorder? The substance causes the release of dopamine very fast and in the excessive amount. So the pleasure because of that substance is more intense and more high. So chances of repeating the substance use is more with it by virtue of this reward system. The another one is GABAergic and glutamatergic imbalance. Alcohol enhances GABA activity. The GABA activity is inhibitory activity. Inhibitory activity means it suppresses the CNS function and inhibits glutamate activity, which is excitatory and causing CNS depression. So alcohol is actually a CNS depressant, not the excitatory substance. In endorphin and opiate system, alcohol increases beta endorphins, so enhancing pleasure. So beta endorphins are also implicated in feeling pleasure. This system is also activated because of the alcohol use. In psychological factors, personality traits like impulsivity and sensation seeking behavior linked to early onset of alcohol use. Neuroticism and anxiety sensitivity. Individuals use alcohol for self-medication. So you must have seen that the person who abuses the substance at the time of intoxication, they are less of anxious. They do the inhibitory system uh, does not work. For example, in driving vehicle, when the person is in non-intoxicated state, they may judiciously use the vehicle, in the controlled speed. And you must have heard about the road traffic accidents in the influence of alcohol. This is because of this uh, anxiety relieving character of the substance. Stress and coping mechanism, self-medication hypothesis, already discussed. Alcohol is used to cope with anxiety, depression, and trauma. So, for a certain period of time, it relieves the anxiety and depression and the traumatic experiences or traumatic memories. Maladaptive coping, lack of adaptive stress management increase alcohol dependence risk. If the coping strategies of that person is weak, so they may try to relieve it because of the by virtue of the substance. Environmental cues, for example, bars, parties, which may also trigger the craving for the substance. In environmental cues for dependent person, maybe the factors for which the person is conditioned, the street, the table, the room in which he used to have the substance, or the environment uh, in which he had used the substance with his friends. If he goes in that environment without alcohol, he may feel like craving for the substance. So environmental cues also plays a factor in causing the alcohol use disorder. Social factor, cultural and societal influences, and countries with high social acceptability of alcohol have higher consumption rate. In the communities where acceptability of substance is normalized, for example, in our setup, tobacco and smoking is a normalized substance abusing activity. A person is smoking in the public places also, although it is uh, banned by the Honorable Supreme Court of India. Then also the people are abusing that tobacco in the social situations also. Family and peer influence. Adolescents and young adults are influenced by social drinking norms. If they are influenced by the person in the family who is abusing substance, or in the friend circle, most of them are abusing the substance, they may also found themselves fond of that. Socioeconomic status and stress. Financial stress and lack of access to mental health care may also play a role. Risk is also linked to high stress jobs and social drinking culture, already discussed. And if the job is highly stressing, the person may go for substance for temporarily relieving the stress because of that job. Now coming to the clinical features of substance alcohol use, there are different stages of this disorder. For example, one is acute intoxication, And a person can have a withdrawal state, person can have an intoxicated state, a person can have a dependent stage. So on the basis of stage, the clinical features are different. For acute intoxication, for mild intoxication, the person may have euphoric experiences, over talkativeness, and feel relaxed. The judgment is impaired, and coordination, motor coordination is also impaired, because of which a person can have accidents, falls, road traffic accidents, and reduce attention and reaction time also lead to these accidents. In moderate intoxication, one may find slurred speech, impaired motor coordination leads to ataxia, disinhibition, and inappropriate behavior and mood changes. The person can become disinhibited or may act violently. Otherwise, he is not. In severe intoxication, marked ataxia and confusion may be there, stupor or drowsiness. One may found nystagmus and diplopia as a ophthalmologic signs. Respiratory depression can occur, hypertension and hypothermia. So this is also a myth that rum causes hyperthermia. Rum creates a hyperthermic condition, but it is not. It causes hypothermia. The person feels like as if he is not feeling the cold, but the cold is actually there. Temperature is there. For example, 7, 8, 9 or 10 temperature. The temperature doesn't change. It is the perception of the person because of the intoxication changes. He does not feel the cold because of the CNS depression. Brain is not functioning properly. Brain is not able to detect the temperature of environment. That is the fact. Now come to the dependence. What is dependence? A definite diagnosis of dependence should usually be made only if three or more of the following have been present together at some time during the previous year. For example, a person has these features 6 months back, now he is abstinent, then also the diagnosis stands. The diagnosis of dependence is stands if out of 6, 3 features are present during any point of time in the last year. So first criteria is a strong desire or sense of compulsion to take the substance. A strong desire means a strong craving. Craving should be there. Difficulties in controlling substance taking behavior in terms of its onset, termination, and level of use. So there is difficulty in controlling the onset to start the abusing substance in the evening or in the morning or any point of time. He cannot control the onset. The person cannot also control the termination. I have to take this much of amount, but after this that much of amount, the person continues to take the substance. So this is discontrol. And levels of use. How much level he has to use. A physiological withdrawal state already discussed when substance use has ceased or been reduced. Evidence of tolerance such that increased doses of the psychoactive substance are required to achieve the same amount of effect of that with the lower doses of the substance. So these are the four: strong desire, difficulties in controlling, physiological withdrawal state, and evidence of tolerance. Further, progressive neglect of alternative pleasures. Before the person was dependent on the substance, now he uh, used to have interest and alternative pleasures like playing game, watching TV, going with friends, doing certain activities which he now not doing because of this substance abuse pattern. So there is a neglect of alternative pleasures. In this neglect, increased amount of time necessary to obtain or take the substance or to recover from its effects is there. So time is spent on to take the substance and or to recover from the effects of the substance. And there may be physical harm such as harm to the liver through excessive drinking and persisting with substance use despite clear evidence of overtly harmful consequences. The person knows that the substance abuse is causing harm to him physically, mentally, financially, socially, or on the personal level, but still he has to take the substance to relieve the withdrawal state. If the person cut down the substance, he will have the withdrawal state, which is very uncomfortable to the person, and to curb that withdrawal state, the person started taking again the substance, despite knowing the harmful effects of alcohol. A person may come in withdrawal state. A person abusing the alcohol and may come for treatment in withdrawal state. So withdrawal state usually starts after 6 to 8 hours of last use, and it can be divided into mild, moderate to severe and complicated withdrawal of alcohol. In mild withdrawal, the person is not dependent on heavy amount. Person can have mild withdrawal like tremors in hands, tongue and eyelids. A person can have anxiety, agitation, restlessness and insomnia, nausea, vomiting, sweating, palpitation, mild hypertension and tachycardia. These are the autonomic instability. These are the autonomic symptoms. A person can have diarrhea, fever and malaise. In moderate to severe, on addition to these mild withdrawal symptoms, one can have seizures, severe tremors, increased heart rate, fever, nausea, vomiting. One can have hallucinations also. Hallucinations means perception without any stimuli. You know about hallucinations? In last lecture you must have read. And in agitation may be increased from previous level. The complicated withdrawals are delirium tremens, Wernicke's encephalopathy and Korsakoff syndrome. What are these? We will learn about the complicated withdrawal. In delirium tremens, what happens is the person becomes delirious. Delirium is a condition in which there is a fluctuation of consciousness. The consciousness of the person is fluctuating uh, over the period of hours in a day. For certain period of time, the person remains all right, seems to be remain all right, and then in disoriented phase, the consciousness is fluctuated. The person will experience marked tremors. Hallucinations can occur in this stage, which can be vivid, terrifying, and particularly in the vision area and tactile modalities. Do you know about the hallucinations? Profound autonomic instability may be found in withdrawal state, which may be hyperthermia, severe hypertension, arrhythmias, sweating, and all the symptoms of autonomic system. High mortality risks are there with alcohol withdrawal when it is untreated. So this should be treated in ICU setup. The complicated withdrawals. The term Wernicke's-Korsakoff syndrome has two syndrome. One is Wernicke's encephalopathy and another is Korsakoff syndrome. When there is severe lack of thiamine, vitamin B1, then one can develop Wernicke's encephalopathy, which is a sudden and severe brain disorder characterized by global confusion, oculopathies and ataxia. You can remember this by GOA, global confusion, oculopathies and ataxia. Oculopathies can be nystagmus, lateral orbital palsy, gaze palsy. Korsakoff syndrome is a long-term chronic memory disorder. When Wernicke's encephalopathy is added upon by the memory impairment, then it is called as Korsakoff syndrome. This syndrome means permanent damage to the brain has occurred. There are lots of damage in the neuronal cells, because of which the person is now not remembering the past or recent memories. The features are inability to form new memories. Anterograde amnesia and retrograde amnesia is the feature of this Korsakoff syndrome. Now, how to evaluate a person who is dependent on alcohol or using alcohol? First, one have to take a comprehensive history. A thorough history helps assess alcohol consumption pattern, consequences, and the dependence stage. Alcohol use history in terms of onset, the duration, the frequency of substance use, the quantity which he is using, if there is binge pattern of drinking, the stage of tolerance and withdrawal symptoms should be asked. Other substances like cannabis or any kind of other dependence or other use like cannabis, opioid, benzodiazepines are comorbidly used by the person or not. Comorbid other psychiatric illnesses are also important like depression, schizophrenia, anxiety disorder. A person with anxiety disorder may be abusing the substance as a medication to relieve his anxiety. So comorbid psychiatric illnesses are also be ruled out. Legal and personal history is also important. If the person is undergoing any trial or not, any kind of case he is facing. The consequences of alcohol use should be ruled out, like medical problems, liver disease, neuropathies, psychological problem, depression, the kind of aggression, social issues like legal and occupational issues should be evaluated. The person should be evaluated as a whole. It is not only the person and the environment around him. Family history is also important. Genetic predisposition, codependence in the family. If the person in the family is also dependent on the substance, so it is better to treat them simultaneously. है ना? Previous treatment attempts, prior detoxification, rehabilitation, medication adherence, uh, whether the person has been treated in the past, what was the outcome, what was the reason for relapse, and all factors should be noted to treat the person in the current uh, scenario. Physical examination is important. We all know about the general examination. In case of alcohol, vitals should be monitored. A person can have malnutrition because of the poor absorption because of chronic alcohol dependent pattern. Dehydration may be there. Signs of intoxication or withdrawal should be noted. In neurological examination, numbness, tingling because of vitamin B1 deficiency. If the person is having confusion, ataxia, nystagmus, memory impairment, to look for the Wernicke's encephalopathy and Korsakoff syndrome. Cardiovascular system, hypertension, arrhythmias, and cardiomyopathy is also be looked upon because a prolonged use of alcohol can lead to uh, cardiomyopathies. So one should not focus on the dependent pattern. One should also focus on the physical part of the person because the person can have comorbid physical and other illnesses. In mental state examination means what kind of mental status the person is having. Appearance and behavior should be checked out whether whether he is having disheveled condition, the person is in intoxicated state, whether tremulousness is there, irritability is there or not. Psychomotor activity like agitation and slowing should be noted. Speech should be noted. Maybe found slurred in case of intoxication or pressured in case of withdrawal. Mood and affect. Patient can have euphoric mood in intoxicated phase and dysphoria and irritability in withdrawal state. Thought process, whether is organized or disorganized, the person is having delusion or not, the person is having perceptual abnormalities like auditory hallucinations, visual or tactile hallucinations, Cognitive impairments like memory deficits, poor concentration, insight and judgment often impaired regarding alcohol related harm. So it should be checked to fulfill the diagnostic criteria of alcohol dependence. Motivation should also be checked, whether the person is motivated to leave the substance or not. The person has voluntarily approached to the clinician, or whether it is involuntary approach, what kind of motivation the person is having, whether he wants to leave the substance, quit the substance or not, what kind of help he needed in the treatment should be noted. So there are certain scales for alcohol use assessment. One is CAGE questionnaire. CAGE questionnaire is the CAGE stands for C for cut down, A for annoyed, G for guilty, E for eye opener. So quick screening can be done by this CAGE questionnaire, whether the person wants to cut down the substance, whether he is annoyed because of this use pattern, the person feels guilty or not, the person uses the substance as an eye opener or not. As soon as the person wakens up in the morning, how much time he used to take the substance. Audit is for alcohol use disorder particularly, and it is known as alcohol use disorder identification test. CIWAAR is clinical institute withdrawal assessment for alcohol revised. This is also a skill. The another skill is SADQ, severity of alcohol dependent questionnaire. On scale on the on these scale, one can assess the severity of alcohol use disorder clinically. Investigations which are required in alcohol use disorder are blood alcohol concentration may be required in case of intoxicated state, liver function test for liver impairment like gamma glutamyl transferase, AST and ALT ratio, which should be more than 2:1 to suggest alcohol liver disease. Complete blood count can show macrocytosis, which leads to increased MCV. Anemia may be found because of the deficiencies of minerals and vitamins. Thrombocytopenia may be the finding. Electrolyte and metabolic panel like hypokalemia, hypomagnesemia, and hypoglycemia also can also be checked. Thiamine levels to determine the Wernicke's encephalopathy. Urine drug screening can be done to assess polysubstance use. Urine drug test can be done if the person is abusing multiple substances at a time. EEG for certain patients, MRI and NCCT brain may be required to determine the permanent damage to the brain cortex. USG abdomen, obviously for hepatic involvement, ECG and endoscopy. Wherever is indicated and required, these tests can be done in a alcohol dependent person. The differential diagnosis alcohol use disorder patient can have is hypoglycemias, can cause confusion, slurred speech, which is similar to intoxication. Hyperthyroidism, hepatic encephalopathy, delirium due to other causes. Delirium is a condition which is not particular for the alcohol withdrawal, complicated alcohol withdrawal. Delirium is a condition can occur in other pathology also, like infections, like electrolyte imbalance and others. Seizure disorder can be differential diagnosis because in a withdrawal state the person can have seizure activity as a withdrawal seizure. Traumatic brain injury, bipolar disorder, generalized anxiety disorder and other substance use disorder can also be the differential diagnosis. Now management we will discuss in a very short, because you are not supposed to uh, treat what are the modalities is prescribed in this management part. So management can be in 4 phases. One is acute management, then is the withdrawal treatment and relapse prevention and psychosocial interventions. So acute management for the person who has arrived at hospital and he needs the detoxification because of that substance. One can have withdrawal treatment. If the person has came in the withdrawal state already, so one can have to treat the withdrawal symptoms. And when the person is detoxified, then the strategy of relapse prevention should be taken into account by means of medications and psychosocial interventions both. So in acute intoxication, supportive care is required. IV fluids may be given for dehydration. Thiamine replacement can be given to replace the vitamin B1 deficiencies, and glucose administration. But glucose administration for energy is not be instituted before the vitamin B1 is given, because glucose metabolism require vitamin B1. If B1 is not there, then this glucose metabolism leads to toxic substance in the brain cells, which can further leads to brain damage. In withdrawal management, the drugs which are used, I am not giving the comprehensive treatment plan for withdrawal state. One should know about which kind of drugs and other treatment are required. Benzodiazepines are given to replace the alcohol. Alcohol and benzodiazepines are uh, act on the same receptor, which is GABA receptor, and these drugs are in calculated dose given in the withdrawal state and gradually taper down uh, in the within the 7 to 10 days, so that one can not have the withdrawal symptoms. Thiamine parenteral and oral should be given. IV fluids for dehydration if the person is agitated. Otherwise, or by virtue of delirium, can be given antipsychotics to curb the agitation. Beta blockers, propranolol and clonidine can be given for autonomic instability. Because of autonomic hyperactivity is there, so these drugs can help to curb them. Carbamazepine, valproate can be given for stopping the seizure. Treatment of co-occurring psychiatric or medical illnesses, if they are these are there. In relapse prevention, when the person is detoxified after in 7 to 10 days or 15 days, the person can be put on relapse preventing drug, which are known as anti-craving drug. And the one is naltrexone, the another is acamprosate, third one is baclofen. There is one drug also mentioned here is disulfiram. Disulfiram is aversive drug. It is not anti-craving drug. This drug blocks the metabolism of alcohol. This drug is given for the patient who are highly motivated and there are chances of relapse in the future. So, with the consent of the patient and one of the family member, this drug is prescribed, and the person is taught that if you take the substance alcohol while you are on this drug, you can have certain embarrassing symptoms like vomiting, diarrhea, flushing of face, and all these things. So because of this aversion, the person is not used to consume the substance, because now he knows that if he will use that substance and I am on this drugs, then I will have certain very discomfortable symptoms rather than the calming effect of the alcohol or relaxing effect of the alcohol. In psychosocial intervention, MET, known as motivational enhancement therapy, if the person is not motivated, can be employed. Cognitive behavior therapy, 12-step program, which is known as Alcoholic Anonymous. In short, it is known as AA. Peer group support, family therapy, if there is impaired family dynamics, there are conflicts between the families, or directly or indirectly with the patient, the family therapy can be done to relieve that stress. Lifestyle and rehabilitation can also be employed, like nutritional support, regular exercise, sleep hygiene. If the impairment of sleep is there, some kind of person used to take the substance because they do not have good sleep. So this is also a case of self-medication that is similar with the anxiety. Vocational rehabilitation, reintegration into the society. Because of the substance use and dependence, he is disintegrated from the society. The person can be reintegrated into society. by the rehabilitation process. Public awareness, policy interventions, community supports are necessary to reduce alcohol-related harm and promote healthier lifestyle, which is the mainstay of any kind of disease, disorder, or illness. The awareness program are being run for various illnesses and for the alcohol too. The conclusion is the alcohol use disorder is a major public health issue, and it can cause significant distress in social, psychological, and medical aspect. Alcohol affects multiple organ system, leading to cognitive impairment, liver disease, cardiovascular complications, and neuropathies. Early identification through comprehensive evaluation can be done and is crucial for effective management. Management includes acute care, withdrawal treatment, relapse prevention using medications like benzodiazepine, disulfiram, naltrexone, camprosate, and psychosocial interventions are also important like cognitive behavioral therapy, motivation enhancement therapy, family therapies, 12-step programs known as Alcoholic Anonymous for long-term recovery and relapse prevention. So thank you. Thanks to all.